Episode 9 Proximal Control, Vascular Surgery Exam Prep, Popliteal and Femoral Artery Aneurysms, FRCS and European Board Vascular Surgery Exam Focus Teaching. Welcome back to Proximal Control. I'm your host, Momia. This is the podcast where we prepare for the vascular surgery exam the same way we practice as a day one consultant with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. Today we are discussing a topic that repeatedly shows up in SBAs, vivas, and short cases because it tests whether you can balance natural history, timing of intervention, and choice of technique without over-treating or missing the limb-threatening presentations. We are covering popliteal artery aneurysm first, then we will do femoral artery aneurysm, and as we go, I will keep highlighting the lines that score marks and the traps that cost marks. Now, let's talk about the definition and classification. A true popliteal artery aneurysm is classically a degenerative aneurysm, and importantly, it can be completely silent until it presents with a major thromboembolic event. In fact, about half of patients with known popliteal aneurysms may progress to a limb-threatening situation, which is why elective repair becomes the gold standard to prevent limb loss. Now, for femoral artery aneurysms, the exam trap is mixing up true aneurysms and pseudoaneurysms. False aneurysms, meaning pseudoaneurysms, are much more common than true femoral aneurysms, and the commonest cause is iatrogenic injury from femoral arterial catheterization, less commonly infection or trauma or IV drug injection. But the higher line is that the healthcare intervention actually dominates this. The textbook even notes that up to 8% of vascular intervention procedures are complicated by femoral pseudoaneurysm. True femoral artery aneurysms are rare, but after popliteal aneurysm, they are described as the second most common peripheral aneurysm, and they often coexist with aneurysms elsewhere and can be bilateral. For femoral artery aneurysm, the classification is as follows. Type 1 is confined to the common femoral artery and ends proximal to the femoral bifurcation. Type 2 involves the bifurcation or the origin profunda or extends into the SFA. Next, we talk about the epidemiology. Now, if we talk about the true popliteal aneurysms are described as the most common peripheral arterial aneurysms and making up about 70% of peripheral aneurysms. They are typically diagnosed in the 6th and 7th decades, and there is a strong male predominance. The textbook quotes ranges as high as 10 to 30 times higher in male in comparison to the female. And that's how you can see this is a male predominance. Now, if a patient has a popliteal aneurysm, they have about 30 to 50% chance of having an associated AAA. The reverse relationship is lower. Only about 10 to 14% of AAA patients have an associated popliteal aneurysm, and if you find a popliteal aneurysm on one side, there is a 50 to 70% chance it's present in the other leg as well. So the safe thinking is, if I diagnose a popliteal aneurysm, I actively look for a AAA and for a contralateral popliteal aneurysm, and that's a mark scoring line. So now pathophysiology and why these aneurysms thrombose. Now the key mechanism candidates need to think about: popliteal aneurysm don't just rupture like AAAs. Their real danger is thromboembolism. The textbook describes a degenerative imbalance in arterial wall constituents, collagen and elastin and matrix regulation, leading to loss of mechanical integrity and aneurysm formation in a multifactorial degenerative process with inflammatory and mechanical and genetic interplay. Then clinically you get turbulent flow, mural thrombus, and embolic phenomena. And because the popliteal segment is a transition zone with branching and distal runoff dependence, thrombosis and embolization are common outcomes. This is why size alone is not the whole story, and that becomes central when you decide who to repair. Now let's talk about the relevant anatomy that actually matters. For popliteal aneurysm repair, you must show you know the popliteal fossa structures. The aneurysm sits close to the popliteal vein and the tibial and common peroneal nerves, and compressive symptoms can involve venous compression or nerve compression. Textbook explicitly lists compressive presentation such as swelling from popliteal vein compression and sensory or motor deficit from sciatic tibial or peroneal nerve compression. So when you choose open technique, medial exclusion bypass versus posterior direct repair, your choice is partly driven by whether you need to deal with those compressive components. For femoral aneurysms, the anatomy that matter is the femoral bifurcation and profunda origin, because if profunda origin is involved, reconstruction choice changes, and that maps directly onto the classification type 2, and that's called Cutler-Darling classification as mentioned earlier. Next, we talk about natural history and complications. This is where SVS and Vivas love to test you. Popliteal aneurysms can be silent. Textbook states that acute limb-threatening ischemia from abrupt thrombosis of the aneurysm or obliteration of tibial vessels is a feared presentation, and in conservatively followed patients, this can occur up to 50%. Of those presenting acutely in that way, the estimated limb loss is 20 to 60% and mortality is 12%. Now you can assume how significant these are. That's brutal natural history, right? And it explains why early elective repair is often favored. Compressive symptoms are less common unless the aneurysm is large. The textbook explicitly says local compressive symptoms are uncommon unless the aneurysm is greater than 3 cm. And then patients may describe fullness or pain behind the knee, swelling from vein compression, or nerve symptoms. Rupture is described as rare, less than 5%, but feared. The classic symptoms is severe pain behind the knee, and there are reports of rupture into the popliteal vein causing AV fistula. Now, femoral artery aneurysm. Pseudoaneurysms are common, iatrogenic, and can be infected or traumatic in some settings. True aneurysms are rare but can present asymptomatically or with complications. The textbook describes symptomatic femoral aneurysms presenting as a pulsatile groin mass with or without pain or bruising. Leg swelling, sometimes large due to femoral vein compression or DVT, and symptoms of chronic ischemia due to thrombosis or embolization. So these could be the presentation of femoral aneurysms. So if you see older man with pulsatile groin lump and swollen leg, you should be thinking femoral aneurysm compressing vein or pseudoaneurysm post-access, and you must separate those. Now let's talk about the clinical examination, and let's make it exam safe. For popliteal aneurysm, the presentation clusters into first, incidental finding, sometimes from imaging for something else. Second, chronic embolization or thrombosis leading claudication or distal ischemia. Third, acute limb-threatening ischemia, which is the feared presentation and carries high limb loss risk, which we already have discussed, which is 20 to 60%, and the mortality was around 12%. The fourth is the compressive symptoms, usually large aneurysms with venous or nerve symptoms, and by large we mentioned more than 3 cm. Fifth is the rare and that is rupture, which we say less than 5%, and they cause severe posterior knee pain or possible AV fistula. These are the presentation of the popliteal aneurysm. In a short case, if you palpate a popliteal mass, you must not stop there. You say, I will examine both legs, assess distal pulses and ischemic signs, and I will actively screen for contralateral popliteal aneurysm and a AAA association. And the number to justify that are the association rates. So if you have a popliteal artery aneurysm, 30 to 50% chance of having AAA. If you have a AAA, 10 to 14% chance of having a popliteal artery aneurysm. So, however, you have a 50 to 70% contralateral popliteal artery aneurysm chance. Let's talk about assessment. Here's the safe structure you can use in any viva or clinical station. I'll assess the patient, the limb, and the aneurysm, then decide urgency and technique. So, step 1, assess the clinical urgency. Is this an incidental aneurysm? Is there distal embolization? Is there acute limb threat? Is there infection? Is there compressive symptoms? Step 2, assess the limb status and runoff. If they have distal vessels occlusion or poor tibial runoff, that changes strategy and risk. Step 3, assess patient fitness and life expectancy, because elective repair is generally done in ambulatory patients with reasonable life expectancy. Step 4, assess anatomic suitability for open versus endovascular repair. That's a safe way to answer, and it scores marks. Now let's talk about some differentials. Popliteal fossa mass, remember the differentials such as Baker's cyst, soft tissue tumor, lymph node, popliteal vein thrombosis, or varix, but a pulsatile mass should always trigger aneurysm thinking. Now, groin pulsatile lump, the femoral pseudoaneurysm is common post-access. True femoral aneurysm is less common. Also consider lymphadenopathy, hernia, abscess, sarcoma, and in the infected setting, mycotic pseudoaneurysms. Now, investigation. Investigation are straightforward, but the exam wants the sequence and the justification. For peripheral aneurysms, textbook states duplex ultrasound with B-mode imaging is the gold standard for confirming the diagnosis. And because 10% of AAA patients also have a popliteal artery aneurysm, popliteal imaging should be considered for part of the workup for AAA patients. Once confirmed, if repair is anticipated, you need arterial imaging to define anatomy and plan repair, including catheter angiography, MRA, or CTA. The key interpretation thing is, don't justify image the sac. You must assess inflow, outflow, and tibial runoff, because thrombosed tibials or poor runoff drive limb risk and can shift you toward urgent strategies. Now let's talk about the management. Now we get where the marks are gained or lost. Who needs repair? Textbook is very clear that symptomatic aneurysm should be considered for expedited repair. And this includes clinically asymptomatic patients with clinical or angiographic evidence of thromboembolism. For asymptomatic aneurysm, natural history series show wide ranges, from no complications at 5 years up to 57% complication rate with 18% limb loss at 2 years. Now here's the key exam point. Complication rates are higher when the aneurysm is larger than 2 cm, but size alone is not the only indication. Presence of mural thrombus increases embolic risk. Many authors recommend repair of any popliteal aneurysm exceeding 2 cm to prevent thromboembolism and avoid limb loss. Some uses 2.5 cm or even 3 cm threshold and use mural thrombus presence to decide borderline cases between 2 and 2.5 cm. So you can safely say, I consider repair popliteal artery aneurysm for the following context. Symptomatic popliteal artery aneurysm, for embolizing popliteal artery aneurysm, And in the case of asymptomatic popliteal artery aneurysm, I consider repair above 2 cm, especially if there is mural thrombus or other high-risk features while balancing patient fitness and life expectancy. And now, textbook states elective repairs have already superior outcomes compared with emergency operations. 1% mortality and 1.4% amputation for elective versus 4% mortality and 8% amputation for emergency. And that line is really important. Now, open surgical options. You must be able to describe the main open operations safely. Option 1. Exclusion and bypass. The classic technique. This popular approach was first described by Edwards in 1969. Proximal and distal aneurysm ligation with saphenous vein bypass. And in the exam, I would say for exclusion and bypass, I use a medial approach, control the artery proximally and distally, ligate or exclude the aneurysm's inflow and outflow, then perform a bypass ideally with autologous saphenous vein to restore inline flow to the distal popliteal or tibial target. And the key pitfall is that exclusion does not always stop sac pressurization because collaterals can continue to fill the sac, so compressive symptoms may persist. So next, let's talk about direct posterior approach repair then. Exclusion bypass achieves the primary objective, that is prevent thromboembolism and limb loss, but it may not address the secondary objectives like compressive symptoms and the theoretical rupture risk, because collateral circulation can continue to expand the aneurysm sac. So, if the patient has compressive symptoms, direct posterior repair allows you to directly ligate collaterals. So, the exam safe answer is for posterior repair, I position the patient prone, incision in the popliteal fossa, carefully protect the popliteal vein and the tibial nerve, open the aneurysm sac, ligate the collateral branches under direct vision, and reconstruct the artery, often with an interposition graft or vein, aiming to decompress the fossa and eliminate the embolic source. And the classic pitfall is nerve or venous injury in the tight fossa. Now, what about the endovascular options? Endovascular popliteal aneurysm repair. In exam, you must show you know the aim and the limitations. Endovascular repair aims to exclude the aneurysm using a covered stent graft. The exam point is that while this can achieve exclusion and avoid dissection in the fossa, it's dependent on landing zones, vessel size match, and durability in a flexion segment. And you must be prepared for loss of patency and fracture risks, especially in poor anatomy. Okay, what I can say safely, technique choice depends on clinical objectives and anatomy. If you are using an exclusion bypass, remember compressive symptoms may persist from collateral sac filling, which is why posterior repair is favored when compression matters. So in endovascular repair, you still must show the same thinking. You are trying to meet the objective, thromboembolism prevention and limb salvage, while matching method to anatomy and scenarios. Now, what about the femoral artery aneurysm? Okay, for femoral artery aneurysm, first, you need to know, is this pseudoaneurysm? Is it post-access, potentially infected, potentially expanding? Or a true aneurysm with atherosclerotic association and other aneurysms? The textbook clearly emphasizes pseudoaneurysms are more common and iatrogenic. For true femoral aneurysms, you define it 1.5 times dilatation as like other aneurysms, and you classify it with Cutler-Darling, which is type 1 or type 2, based on whether the bifurcation or profunda or SFA origin is involved. Now, the common symptomatic presentation is a pulsatile groin mass, sometimes painful or bruised, leg swelling from femoral vein compression or DVT, and symptoms of chronic ischemia and thrombosis or embolization. Investigation is again duplex first, then cross-sectional or angiographic imaging if planning repair, especially if profunda origin is involved. Now, the management principles, again, staying within what we have already discussed. Symptomatic lesions, expanding lesions, lesions causing compressive symptoms or embolic or ischemic symptoms, these generally push toward intervention. And for true aneurysm involving the bifurcation, Kotler-Darling type 2, the operative planning must preserve profunda perfusion because profunda is crucial collateral supply. So, you can say in the exam, for open repair of a true femoral aneurysm, I expose the common femoral artery and bifurcation via groin incision, obtain proximal and distal control including profunda and SFA if involved, exclude or resect the aneurysm segment, and reconstruct with an interposition graft or patch strategy, depending on extent. And the key marking point is preserving profunda flow when the bifurcation is involved, because profunda is the lifeline if the SFA fails. That's the safe answer. Now, what do I do in real life? Let's bring into real decision making. If you are in the clinic and you find an incidental popliteal aneurysm, you confirm it with duplex, you document size, mural thrombus if present, and you check distal perfusion and runoffs. You screen the contralateral popliteal and assess for AAA. Because of strong association as popliteal artery with AAA 30 to 50% and contralateral popliteal artery 50 to 70% aneurysm chance. Then you decide surveillance versus repair. And the textbook helps here by mentioning symptomatic aneurysm should be repaired and asymptomatic aneurysm more or equals 2 cm are commonly recommended for repair, especially with mural thrombus because complication rates can be substantial and acute events can be devastating. Now, if you're on call and a popliteal aneurysm thrombose and present as acute limb threat, so your thinking should immediately be high limb loss risk because textbook quotes conservatively followed patients can progress to limb-threatening ischemia in up to 50% with limb loss 20 to 60% and mortality 12%. And that's why these patients are treated seriously and early. For femoral aneurysms presenting as groin mass and swelling, you ask about access history, anticoagulation, fever, infection risk. Duplex will usually sort a pseudoaneurysm versus true aneurysm quickly, and then planning follows. Let's summarize the management. Confirm diagnosis with duplex ultrasound, and that's gold standard. In popliteal artery aneurysm, screen for AAA contralateral popliteal artery as well. Repair symptomatic popliteal artery aneurysm and asymptomatic with embolic features, or if it's more or equals 2 cm. Consider repair for asymptomatic popliteal aneurysm as mentioned more or equals 2 cm, especially with mural thrombus, high-risk features, and thresholds of 2.5 to 3 cm are sometimes used with judgment. Choose technique based on objectives and anatomy. Exclusion plus vein bypass addresses embolic risk. Sac may still expand via collaterals. Posterior direct repair when compressive symptoms matter, direct collateral, and by this approach, direct control of collaterals can be achieved. For femoral artery aneurysm, distinguish between pseudoaneurysm versus true aneurysm. Classify true femoral artery aneurysm with Kotler-Darling and plan reconstruction with profunda preservation if bifurcation involved. Now let's talk about the outcome of the repair. If we talk about the elective versus emergency popliteal artery aneurysm repair, elective has a mortality of 1% and amputation rate of 1.4%, whereas in emergency, the mortality is 4% and the amputation rate is 8%. Now this is the time for some rapid-fire question sections. Are you ready? Let's go. First question. A patient with 5.5 centimeter abdominal aortic aneurysm also has a 3 centimeter popliteal aneurysm. Which should be treated first? Well, the abdominal aortic aneurysm, because the rupture risk determines the priority, and 3 centimeter aneurysm, it does not mention that is symptomatic or there is any thrombus load, which means the limb is not threatened. Question 2. What proportion of popliteal aneurysms are bilateral? You know by now, it's 50 to 70%. Next, what proportion of patients with popliteal aneurysms have a coexisting abdominal aortic aneurysm? Now you know, this is 30 to 50%. What if I ask you the other way around? How much of AAAs are having association with popliteal artery aneurysm? That's 10 to 14% only. Okay, at what size an asymptomatic popliteal aneurysm generally considered for repair? We already said greater or equals 2 cm is the treatment threshold for asymptomatic popliteal artery aneurysm. For endovascular popliteal aneurysm repair, what landing zone length is required proximally and distally? This is 2 cm. So adequate sealing zone is achieved by having 2 cm of landing zone both proximally and distally. What distal runoff is usually required for endovascular popliteal aneurysm repair? This is important, at least 2 vessel runoff. If you have poor runoff, you should consider for open repair, not endovascular. Next, is primary stent grafting appropriate in acute limb ischemia caused by a thrombosed popliteal aneurysm? No, acute thrombosis requires limb salvage strategy first, often surgical or hybrid. What is the first-line investigation for suspected popliteal aneurysm? Well, duplex ultrasound, we already said, and this confirms aneurysm, thrombus, and the runoff without delay. Next, what is the most common presentation of popliteal aneurysm? Is it rupture or embolism? We already know it's embolism or thrombosis. Rupture is rare. We said that it's less than 5%. Thromboembolism drives the morbidity. What is the usual repair threshold for true femoral artery aneurysm? We did not mention it earlier, however, in some of the book it's mentioned greater than 3.5 centimeters. So for you to remember, the treatment threshold for asymptomatic femoral artery aneurysm is greater than 3.5 centimeters. Next question. After diagnosis of popliteal aneurysm, what additional vascular territories must be imaged? The abdominal aorta, contralateral popliteal artery. We already said that. What is the standard open surgical principle for popliteal aneurysm repair? So the standard open repair is exclusion or ligation with medial bypass using vein. That's the standard. But we discussed about posterior approach, especially when compressive symptoms are there. Now let's talk about few scenarios. Scenario 1. Symptomatic popliteal artery aneurysm with good runoff. This is a 68-year-old man with calf claudication and intermittent blue discoloration of the toes. And on examination, he has palpable pulsatile mass in the popliteal fossa with preserved distal pulses and no rest pain. How would you manage? Given this presentation, my working diagnosis is a symptomatic popliteal artery aneurysm with distal embolization but preserved runoff. My next step would be duplex ultrasound to confirm aneurysm size, mural thrombus, and runoff, followed by CT angiography for anatomical planning. Imaging shows 2.8 cm popliteal aneurysm with 2 vessels tibial runoff with suitable proximal and distal landing zones. Now what you do? Well, my management for this aneurysm, as this is symptomatic and therefore requires repair. In this patient with good runoff and favorable anatomy, I would offer endovascular stent graft repair, ensuring at least 2 cm proximal and distal landing zone. This case justifies endovascular repair as this patient has good runoff and adequate sealing zone. I would also screen for contralateral popliteal aneurysm and AAA, giving the strong association. Post-procedure, I would institute antiplatelet therapy and duplex surveillance. Now another scenario. Thrombus popliteal aneurysm with poor runoff. This is a 78-year-old man presenting with sudden cuff pain and numbness. Examination shows a cold foot, reduced sensation, and absent pedal pulses. A pulsatile mass is palpable in the popliteal fossa. This is most consistent with thrombosed popliteal artery aneurysm causing acute limb ischemia. Initial management is urgent anticoagulation and limb assessment. Duplex and CT angiography demonstrates a thrombosed popliteal aneurysm with single vessel runoff. In this situation, my management priority is limb salvage, not aneurysm exclusion alone. Endovascular stent grafting would be inappropriate due to thrombosis and poor runoff. Therefore, my preferred approach is open surgical repair with aneurysm exclusion and vein bypass to the best distal target, with adjunctive thrombectomy if required. This strategy is chosen because the aneurysm is symptomatic or thrombosed with poor runoff. I would also have a low threshold for prophylactic fasciotomy depending on ischemic time. And that brings us to the end of the episode of proximal control. And next time we will go straight into high-yield non-atherosclerotic causes of lower limb ischemia, which is very important for the exam. The conditions that catch people out in SBS and clinical exams. So keep listening. As always, with your support, we will keep growing together in vascular surgery, because in vascular surgery, control is everything.